Well, hello, Toby. This is Dr. Jerry Cuomo here with Harlan's case now, and just looking straight at the model. Beautiful model work, by the way. That soft tissue gum material is adapted so well. It gives us a clear image. Now I'm going to go ahead and magnify that area. I'm pointing to the lingual aspect, and our abutment design should flow very well with this area of soft tissue. I'm going to try to preserve the interdental papillae, both mesial and distal. You may consider, definitely would like to see the extent of the crown to match that of the adjacent tooth and the adjacent central incisor. I noticed it's relatively thin in the labial area, thin tissue. You can almost measure it with a thickness gauge, so we definitely are going to go zirconia here. The question is how far below the margin of the soft tissue should we go for cementing? Obviously the lingual you can keep right at tissue level, but as you get through the interprox, in case we need to close in on a area of dark triangle. Although Harlan originally had a small little dark triangle in that area between 8 and 9, but I've also relieved with my dental handpiece. I used a gold fluted burr from the Neo company, and took care of just a little bit of undercuts in between on the soft tissue side. And now I'm kind of tracing through the area of the facial aspect again and lingual. So zirconia definitely. I believe we can probably get that scanned, and either Atlantis or whatever lab you were to choose. In fact, Nobel may have their own zirconia abutments process. This is a little drawing and outline. I've been to a course a couple weeks ago which includes an area now that they're pressing to. They're taking Emax and pressing their porcelain and making it an all ceramic bond to margin. You'll see the dotted line there that demarcates the end of the zirconia, and then they bond in the shoulder of the they press in the shoulder of the abutment, and then they etch that, and then they etch the crown with the same Emax press to that margin, and that flows as one piece. So that's where they're heading now. They're keeping the margins more toward the tissue level, and then the dentist is etching both the crown and the margin of the abutment and then bonding them in. So that was a thought. I didn't know if you've researched that at all, or been presented it with other cases. But looks like we'll need to go a little bit sub G here, though, to on the facial and mesial and distal, just slightly scalloped in there for us to cement this case. Obvious angulation prohibits the use of an angled abutment. And so the lower, you can see the lower has a lower incisor. That's tooth number 24, and 25 actually is the one that sticks out outside the arch, the lower arch. So we're looking at somewhat of a compromise. If you look at the occlusal table on that, the flatly worn facet of this lower right central incisor, I believe that caused most of the wear and attrition to the lingual incisal surface of the original right central incisor. So we put the original model together, and we'll see the original tooth in its position. You notice the lingual wear right where I'm pointing, comparing that to the left central. So you're going to end up with some of that same contour on the final. There's not going to be any orthodontics done on the lower. This patient does not want to go through any type of ortho. So it was explained to him that we are going to have an area, which will be more hollowed out, similar to the original. And the other thing is, you might have to come a little more labial to give us an even thickness on your ceramic. So feel free to bring it out a little bit. There's not much I can do with the left central. We're pretty much locked in the Harlan's case here. He does exhibit some wear and tear on that right lateral from tooth number 26, but that's going to remain the same. So obviously you're going to have to come pretty close to what the original cast is. The width of this tooth is identical to the width of its complement, and also the CEJ area as well. The width of the CEJ is going to be very similar to number 9 as well. I took out a pair of calipers and measured both, and I came up with almost identical widths. In fact, here are the calipers now. I'll go ahead and measure them. This is the area of the mesial distal contact of number 9 comparing with number 8. They're identical. And then if we measure the CEJ area, I'm just going to show you how many millimeters that is. I think we were right around a 9. I think we're about, actually it looks like about 9.5 or 9.75. So that's the width in millimeters. And I think soft tissue wise, looks like the crest of the soft tissue is a little bit more apical than that of number 9. So we will be coming up a little bit more. There's the CEJ measurement, and then we can almost, lock that in. So I think we'll need just a little bit more pressure into the pupil, not much, maybe just a little bit more. I'll let you decide. You can measure it yourself with your calipers as well at the CEJ. And I think that's trying to think where else can we discuss. Okay, a little more of a blow up now. We're up around 5 to 8 magnification here, and of course you can freeze frame at any time and just study the dimension. Hopefully your scanning will go well with this. And again, here's the study model. We noticed lingually you can see that there is a triangle there. Okay, that's about it from here, Toby. Feel free to call me, and we can further discuss this case. If you need me to have Harlan come in for a Bispake try-in procedure, let me know, or just go ahead and schedule maybe him to come into your studio to go over the final touches on the color before I receive the case. I know you took a lot of notes, and maybe it might be best to get a refresher in your office on color and go over that again. Other than that, that's about it from here. I hope you can understand the video, and certainly if you have any questions, feel free to contact me at the office. Dr. Jerry Cuomo, just going through Harlan's case here, and we'll touch base later on. Have a good day.